From the editors of Biological Psychiatry and the Society of Biological Psychiatry, this is Biological Psychiatry Live. And I'm Dr. Tamara Gore, the social media editor, and today I'm interviewing Dr. Kristen Eckstrand. Dr. Eckstrand, could you please introduce yourself?
Hi, yes, thanks so much for having me. My name is Kristen Eckstrand. I am a child and adolescent psychiatrist and a postdoctoral scholar in the Department of Psychiatry at the University of Pittsburgh, and I work in the labs of Dr. Mary Phillips and Dr. Erica Forbes.
Thank you so much for taking the time to join us today to talk about your recent publication in our journal. If I could start by asking you, what is actually currently known about how trauma exposure influences anxiety and affective symptoms?
Yeah, it's a great question. I think that what we can all say is that we know across the board trauma is essentially a transdiagnostic risk factor for just about everything in psychiatry. Specific to anxiety and affective symptoms, individuals exposed to trauma are more likely to go on to develop depressive symptoms, anxiety symptoms, and are also at higher risk for bipolar disorder. Usually this falls along the lines of 2 to 3 times increased risk. And not only are people at increased risk for developing the disorder, they're at increased risk for having more severe symptoms and also more likely for those symptoms to persist over time. And most importantly, when we look at factors of treatment in terms of recurrence of symptoms and also sort of treatment resistance overall, we know that trauma is actually associated with sort of symptom recurrence over time and treatment resistance. So what we're doing right now in psychiatry in terms of doing essentially sort of trauma-informed psychopharmacology or treatment, we really don't know how to integrate trauma into treatment approaches in ways that can actually sort of reduce the symptom burden and the severity burden of people who've had a history of trauma exposure in psychiatry. So this is actually a very important problem to try and figure out, is how do we incorporate trauma into our treatment approaches.
So what new information would your study suggest mechanistically for our understanding?
Yeah, so as I mentioned, one of the problems, and again, there's a lot of, this field is ripe for a lot of research questions to be asked. The one that we were really interested in is thinking about the persistence of symptoms over time, is specifically symptom trajectories over time. And what we did here is we really acknowledged that trauma is likely to impact just about every brain system, but we really wanted to focus in on a system that has some validity in predicting future symptom course. And so we looked at reward processing symptoms, which have been shown to predict future symptom course over time, specifically looking at neural response to reward prediction error. Now, reward prediction error is a really interesting concept that measures sort of the difference between actual and expected rewards. And this is important in depressive disorders, anxiety disorders, and bipolar disorders. If there's a mismatch in what you think is going to happen versus what actually happens, it may change your desire to approach whatever that thing is or avoid what that thing is. And that might change your ability to interact in an environment in a way that either gives you positive things or exposure to other negative things potentially. So we're looking at neural response to reward prediction error. And what we're really interested in here, the aim of the study is to determine how lifetime trauma exposure influences prospective relationships between neural reward circuitry and trajectories of affective and anxiety symptoms over 1 year. And what we found here in the study is that trauma exposure interacts with neural reward circuitry, specifically activation to prediction error in the ventral striatum and the amygdala to predict future hypomania symptoms. So, for example, the combination of greater trauma exposure and greater ventral striatum activation to reward prediction error resulted in a shallower increase in hypomania severity, as opposed to the combination of greater ventral striatum activation and lower trauma, where we actually saw a much steeper increase in 1 year trajectory. This sort of suggests that trauma is somehow blunting the magnitude of the reward-related behavior in some way, shape, or form. We're not quite sure what yet. We have some hypotheses there. The other interesting relationship is that we kind of saw the converse for the amygdala, where greater activation to prediction error in the amygdala with greater trauma exposure resulted in increasing one-year hypomania trajectories, as opposed to the greater trauma, or sorry, lower trauma exposure and greater amygdala activation, which actually resulted in decreasing hypomania trajectories over the course of 1 year, which we think may be more reflective of the amygdala's role in sort of the arousal component of hypomania, potentially not reward seeking. But the most important thing to take home here is what we saw here is that there is an interaction between neural response to reward and the severity of lifetime trauma exposure in terms of the number of traumatic events, and how that predicted in differing ways symptom trajectories over 1 year. And that especially in the amygdala, where we saw in one setting, trauma resulted in an increase in hypomania, but in another setting resulted in a decrease in hypomania based off of the region in the brain that we were looking at the interaction with.
So with that, all of that in mind, all of it, what new strategies for treatment would you think could be explored?
Yeah.
Findings?
Yeah. So I think that there's sort of, two pieces to this. And one is that, there's so many wonderful scientists across the board are looking at sort of novel ways to treat psychiatric illness. And, this certainly isn't to say that we should all drop what we're doing and incorporate trauma. But it is to say that, for those emerging treatments, and certainly for current treatments as well, we should look at how well is this treatment working in the setting of trauma exposure. And this trauma is a very complex thing. When it happened, how frequently it's happened, it is complex. And in our study, all we did was sort of quantify the number of traumatic events, very similar to how the ACEs study has quantified number of traumatic events. It's a solid marker. And so, I think that for current treatment studies, existing treatments, you could certainly look at how does treatment influence, or how does trauma influence course of treatment and efficacy of treatment. It's a very simple way. But I think the more, specific to this study is that if we're looking at sort of more personalized treatment markers and using some more of the novel treatments that are coming up in terms of neuromodulation studies, we can actually look, it'd be interesting to see, okay, well, if we look at how much trauma someone has had and the symptom course that they're experiencing, if they're experiencing depression or experiencing hypomania, we may be able to say, listen, if this is sort of a hypomania, concern, maybe we need to target the amygdala. Either in this case, we would want to turn it down if they've had trauma. Alternatively, you could try doing some type of neuromodulation to sort of target the ventral striatum. So I think it looks at sort of that combination of actually doing more targeted treatment, acknowledging the difficulty that people have had to overcome and the symptoms that they're experiencing. So I would look at it from both of those two perspectives.
I mean, I think you and your study and you have made an excellent case for taking trauma into account when we think about treating our patients. So thank you. And thank you for your time today. I really enjoyed speaking with you.
Thank you.
Thanks.
Mm-hmm.